Hello everyone, I'm Golasa. I'm a clinical research assistant in Calgary Liver Unit at the University of Calgary. I'm going to talk about treatment outcomes with second generation DAAs in all hepatology and infectious disease clinics in Calgary. There has been great progress in HCV treatment. In large clinical trials, most patients achieved SVR with shortened duration and interferon-free regimens. Even difficult to treat patients such as cirrhotic, liver transplanted, and HIV co-infected patients. There is limited published data on real-world treatment experience with second-generation DAAs in Canada outside Toronto. Our objective was to assess treatment outcomes with the second-generation DAA in all hepatology and infectious disease clinics in Calgary. We reviewed 362 HCV-positive patients treated with second-generation DAA, excluding telaprevir and boceprevir, over an 18-month period from March 2014 to November 2015. Demographic, clinical, and lab data, including age, sex, genotype, viral load, fibrosis stage, and SVR data at 12 weeks after the completion of treatment, and estimated GFR at baseline and follow-up were collected retrospectively. Baseline clinical data. Median age was 57, 63% of patients were male, and 75% of patients had genotype 1, 7% genotype 2, 15% genotype 3, 2% genotype 4, and 0.5% genotype 6. And median HCV RNA at baseline was 5.8 logs. Liver stiffness measurement, median liver stiffness at baseline was 10.3. 41.4% of patients were cirrhotic. 12 patients had HIV co-infection. All HIV co-infected patients were on a stable antiretroviral regimen with restoration of immunity and undetectable HIV RNA. Only one patient had HPV co-infection. 5.8% of patients had hepatocellular carcinoma, and 2.5% of patients were liver transplanted. DAA treatment regimens included Harvoni in 58% of patients, sofosbuvir RBV in 21% of patients, sofosbuvir cimeprevir in 6% of patients, sofosbuvir peg RBV in 6% of them, Harvoni RBV in 4% of patients, holkirapac RBV in 2% of patients, holkirapac in 0.8% of patients, and cimeprevir peg RBV in 0.5% of patients. To date, SVR data at 12 weeks after the completion of treatment is available in 84% of patients, and 91.5% of them achieved SVR. In patients who relapsed, DAA treatment included sofosbuvir RBV. 50% of patients on sofo RBV relapsed, 14% of patients on sofo peg RBV relapsed, and 13% of patients on cimeprevir sofosbuvir, and 6% of patients on Harvoni relapsed. Overall, 8.5% of patients relapsed. In terms of impact of DAA treatment on liver stiffness measurement, to date, 26% of patients had available data on liver stiffness after the completion of treatment, and 83% of patients experienced fibrosis regression from median 12 at baseline to 7.7 at follow-up, which was statistically significant. In remaining 17% of patients, liver stiffness remained almost unchanged from 7.7 at baseline to 8.5 at follow-up, which was not statistically significant. In terms of impact of DAA treatment on renal function, one patient developed worsening renal function approximately at 16 weeks after starting Harvoni, and in this patient, estimated GFR at baseline was 66, which decreased to 52 at follow-up. In conclusion, in this large Canadian cohort study, we report real-world clinical outcomes in every HCV-positive patients known to be treated with second-generation DAAs to date in Calgary, Alberta. Similar to clinical trials and other real-world experiences, such as HCV-targeted study, treatment was well-tolerated and highly effective, with 91.5% of patients achieved SVR. At the end, I'd like to thank all patients, research, and clinical staff at the Calgary Liver Unit, Health Education Housing Medical Clinic, and Southern Alberta HIV Clinic in Calgary, Alberta.
I guess we'll, for the interest of time, we'll move on to the next presentation. Thank you very much.